residential services in just one county in Ohio. And as a new CEO came in and a new leadership team came in, we really looked at, and a lot of market study and surveys of people were done to ask what is actually needed, what needs are being met, and what is not being met. And out of that came this sort of complete transition and reinvention of the organization to serve the whole state of Ohio to, I don't even know what number it is, multiply by 8. So to grow really quickly in a short period of time, really focused on what are the gaps and what are the holes and how do we meet people where they are. And one of the things that I think anyone who knows anything about the neurodiverse populations is that essentially every system was not created for them. So when you think about schools, when you think about hospitals, when you think about the doctor's office, when you think about the library, the fair, anything, like they're welcome, but it wasn't created for them. And so we essentially set out on a mission to say what would happen if we created for this population and then said everybody else is welcome. So we created dental programs and primary care programs and occupational and speech therapy and schools and all of these systems and said we're going to make it specifically with these populations in mind. So everything from how the architecture is done to how clinicians are trained to how intake, how people access services, all of that is built around the neurodiverse populations. And then we said everybody else is welcome. And an interesting thing that we found is that actually it's 50-50. 50% of the people who get services from us for primary care, dental services, psychiatry, counseling, they do not have an intellectual or developmental disability, they do not have autism, they do not have ADHD. They're just people in the community who want really great services, and they come in and they're like, hey, I really enjoy getting it in a calmer space, in a more streamlined space, in a space where everyone is accepted. And what we're finding is that the whole concept of universal design actually universally makes everyone feel better. And so I think approaching it from how do we turn things on their head and be willing to do something that hasn't been done before is paying off and has really allowed us to grow unbelievably fast. Now that comes with its own challenges, but the demand just keeps rising as we keep saying, well, what if we tried this and what if we did this?
I love that. That makes so much sense. I'm going to stick with the providers for a minute and Becky, talk to you about, you're running services for mostly kids in this venue, and there's a lot of cool things that you're doing differently at Marikey, which is the largest nonprofit provider in the country, about $750 million in annual revenue. What I know about large organizations is sometimes it's like turning a cruise ship instead of turning a sailboat. It's harder. But talk about your experience and kind of what are some of the cool things you want to leave the audience with.
Absolutely, but first, happy birthday. We have a birthday in the audience.
I love that.
She's right here.
Either that or she really likes tiaras.
What'd you say?
Or she might just like tiaras.
She might like tiaras too much. Happy birthday. Absolutely. So, as Stacy mentioned, I do work for the largest nonprofit in the nation. Our children's services are something that have spent the last couple years pivoting, really looking at preventative care for several reasons. One is, and it's true on most services, the sooner you can get some type of support or help, the less likely you're going to need longer term care or maybe the duration of what service that you have you may need. And a lot of times when people think prevention, I think they have this naive concept of early intervention. And they're thinking, oh, if we can get involved, birth to 3 or something like that. But for us, prevention really is anything that we can put in ahead of time that either provides that stopgap into something longer. And we've really been focusing on transition services as well. Now that has a lot of buzz around it, and everybody always thinks like work or job readiness skills or getting ready to go to college. But for us, it's really how can we provide an independence into adulthood. And in many of the states that we provide services, the children's services and what's available for us to provide as a provider does not crosswalk then into adulthood. And the systems don't really talk. So you could be getting case management as a child, but the way you access case management as an adult is very different. And then we have a lot of families who their children are not ingrained into their communities. So starting to look at preventative services that allow people with IDD and autism and ADHD to access their community. We're running a pilot right now in the central part of Pennsylvania with grant dollars that we are getting teenagers their driver's license. And the reason we have to do this is because their parents don't drive. So there's no way for them to get supervision while they're driving and count all your hours so you can actually get a driver's license. Well, getting that driver's license is then going to open them up into employment, education opportunities, and maybe even the ability to be out on their own in their own apartment as they go. We look at partnerships as well. And I do speak just from the children's lens, but a lot of our preventative services here lately are also focusing on making sure that our children aren't being removed from their parental homes. What can we do ahead of time? Because we do find that once something like that has occurred, as they age and get into the older population, we then see them on the street, involved in crime, gangs, things like that. We have in New York services that are gang preventionary program, so we're actually helping kids get off the street, and this is all array of diagnosis, much like Jen has mentioned. It's about a 50-50. You'll see that you'll have someone with autism or ADHD coming in, but then maybe not, maybe they're peer. So we're also helping facilitate those peer relations. So a lot going on in multiple states. But Stacy, I'll turn it back over to you.
Yeah, that's great. Thank you. I'm going to stay with reimagining and innovation and then end with the think tank. So Chris, I mean, you truly built something that didn't exist. You saw a need and you filled it. Tell us kind of how you're seeing that adoption. What are folks saying about it? What are you learning? And what should we do more of?
Yeah, so I think fundamentally what I was kind of missing in the market was, I don't know if, have you guys heard of the neurodiversity model? Everyone? Okay, I see some nods. So neurodiversity is like biodiversity. It's just good. So it's not necessarily that we need to fix people who have neurodivergencies with ADHD, autism, whatever it is, but we need to change the entire system and empower people, whether they have neurodivergencies or not, to work with their strengths and achieve what they can achieve in their life and what they want to achieve. And so that was really important to me, and what was missing for me in the market was solutions for people who are neurodivergent that wasn't trying to fix us. They weren't just trying to increase or decrease our symptoms or decrease our anxiety or decrease our depression. Those are obviously important things, but I wanted to think through what my goals would be and how I wanted to design my life and how to be able to advocate for myself with other people in my life, whether that's my employer or whether that's my school system. And so what we really wanted to create was something where going through felt empowering instead of felt like you were being fixed. And so what we see is people coming through who don't look like the average ADHD or autistic person, but it's someone who maybe because of cultural reasons was not willing to admit that they have ADHD, or because of whatever reasons that they didn't want to get through that diagnosis. And so it's a different subset of people who have been, yes, underrepresented, but also too are ready for something that's more empowering and see results that are more in terms of better ability to manage your ADHD, more well-being, reduced life impairment. So the results that we're seeing are, I mean, I'm obviously biased and I talk to my users every day, but they're phenomenal in that people are able to get new jobs, not because they reduced their symptoms, but because they rethought what their strength was and what their passions were, and therefore what their new job should be. And so once they have that new job, of course they're going to be happier. Maybe their symptoms, maybe their time management still is bad, but that's okay because they're in a job that doesn't require as much time management anymore. So I think a lot of it for us is about redefining and rethinking what neurodiversity care even looks like and what's missing in the market, because everyone has a different experience, everyone's in a different part of their ADHD or their neurodivergence journey, and you're gonna need something different. And for me personally, the part that was missing and that I'm really happy that I get to see other people thriving from is this more empowering aspect.
That's amazing. I love that. Thank you. Jay, you said something during our prep conversations which stayed with me, and I hope that you comment on this as well with your other remarks, but you said we have to focus on how we ensure that we truly include IDD, ASD into CCBHC design and crisis continuum nationally. From a former head of the Department of DHS in Indiana, what do you say to that? How do we do that?
Yeah, well, I'm glad that, because I remember saying that. I say stuff all the time I don't remember, so I'm glad that's what you took away from it. Maybe it's helpful to level set. There was a lot of acronyms in there, so let's maybe back up and talk about the system that I'm talking about right now is for people, specifically people with significant intellectual or developmental disabilities, usually with a dual diagnosis of mental illness. The studies show that about 30% of folks with intellectual disabilities also have corresponding mental illness. They also are pretty clear that's pretty underreported. And so what we're talking about in this system is we're talking about Medicaid, right? And that's a really important place to start because, I'll say I'm a recovering lawyer, right? So I used to be a lawyer, and when I was a lawyer, I was in legal aid, I sued the state on behalf of people with intellectual disabilities a lot, in the Medicaid space. And now I jumped over to the state and I realized as an outsider, I knew nothing about Medicaid, right? You think you know about Medicaid, then you're in the space and you realize that it is way more complicated than you could ever imagine. But it's an important place to start because, and then the system that we're talking about, so the system for significant intellectual disabilities looks different in different states, but the common thread is some sort of Medicaid waiver, which allows direct service providers to go into people's homes and communities and provide them services. That's essentially what I'm talking about here. So back to the Medicaid situation. The thing to know about Medicaid, obviously, it's a state-federal program, so the state governments pick up a portion of the tab, and then federal government comes in with the rest of it. And that's important because state fiscal pictures right now are extremely dire. There's a lot of federal COVID relief money that's expiring. And if you want to ever, you may think, oh, well, intellectual disabilities, behavioral health, maybe that's exempt because it feels good. If you ever want, to see somebody's eyes light up, ask a state budget director about across-the-board cuts, and they will talk to you for hours about how they can't wait to implement these 15% cuts across the board. That is coming. That's happening right now. It may start in red states like Indiana, but it's coming everywhere. And so the reason I bring that up is not to paint like a really dire picture necessarily, although it is that. But when it comes to innovation within this space, we can't just talk about sort of more money for more services, because that's probably not coming, right? That sort of brings me to the common story that I heard when I was on the mental health side, but I was talking to the IDD community about where the problems are, and the kind of common theme was the providers just need to do better, right? Like the community mental health care providers, if they wanted to, they could easily serve this population, and they're choosing not to. And it was never a story that really struck me as plausible. I mean, in general, I think mental health providers are people who are in this space for the right reasons, and these are community-driven organizations. But the problem with that is actually structural. Okay, there is a clause in the federal code of regulations that says in order to be eligible for a intellectual disability waiver service, your functional limitations, which are what they use to become eligible for those, cannot stem from mental illness. So because of that little clause in the code, the system is like spectacularly siloed from the very beginning, right? Almost comically siloed. Like it's like you hear like these stories that if they weren't so sad, they'd be hilarious. Like it's just like, you have to go down the street to talk to your ID provider about this. There's no sort of like conversation in there. And that structural problem, and now all that precursor, all that backdrop, Stacey, I'm getting to your question, which is there's a new model of care in behavioral health called, I'm going to fit in a think tank, I think, so there's a lot of, so this new model of care in behavioral health is called Certified Community Behavioral Health Clinics, or CCBHC. Most of you probably have heard of the acronym. You probably actually don't know like why it's important, honestly, because most people don't. Like even the field itself, to me, struggles with messaging around this. But this is an absolutely, potentially dramatic change in the entire delivery of behavioral health care. And the reason for that is that it fundamentally changes the payment model away from this sort of fee-for-service, grab what you can model of care to a situation where providers can be compensated for the actual costs of delivering care that their community needs, right? And that's a really, really big change. And where IDD fits in, and Jen, I'm glad in our call you kind of called out that this is almost entirely theoretical at this point, so that's an important thing to say. This has not been done. There's room for innovation here. We have a provider in Indiana who has stood up with a grant we gave them. I gotta stop saying we, I'm not we anymore. A grant that the state gave them to set up a one-stop shop for children with significant intellectual disabilities in their families. And they plan on continuing this. And they think they can fund about half of it through the CCBHC model, which is a pretty big step off from none of it, which is how it was before. So because CCBHC allows you to take a look at your community's needs, including the needs of people with IDD, and build a rate based on those needs, it's a potentially, stress potentially, because this has not actually happened yet, but it is a potentially lasting solution to this silo problem.
Yeah, I mean, historically, the onus of the burden of changing the system has been on the backs of providers who have no margin, right? And the story of everyone on this stage has been, you innovated, you created something new with braided funding, or you went for, right to consumer, or you looked at something alternative than staying within that model and that framework. And there's a willingness or an unwillingness of regulators and payers to embrace more flexibility in funding. I heard you all talk about. So integrated care is something that we, the CCBHC model and others that we all talked about in this. How would you see the difference, like Chris, if you could bill for that, and if you can go to your insurance and say, hey, I want this service, will it be covered? I mean, that's a game changer. Tell me about those conversations, or if you've started to think about how that can happen.
Yeah, definitely. The number one thing that when people come to us is say, does my insurance pay for this? They expect it to be paid for because it's a service for ADHD or for autism or for neurodivergence. And so far, we have not been able to say yes personally, but there have been people in the audience who have done great work within the ADHD space and have things already covered. And we're in these conversations as well. And the issue is that payers are starting to see that ADHD and neurodivergence is important, yes, but also that there's a variety of different solutions that all move different outcomes. And it's going to take time to be able to, as a new service, as something that hasn't been proven out yet, to be able to prove those outcomes and to be able to get those things covered. But I'm feeling really optimistic because, one, we have employers paying for it, and two, we have HSA, FSA also paying for it. So people, if they are willing to advocate for themselves or willing to look through for multiple avenues of funding, are able to get that, but not all the way there, of course.
Right, we're getting there. Jen and Becky, I know integrated care, different models of braided funding. You have shown in your programs, and Jen, I know you might want to speak to this first, about how it actually reduces the cost of chronic care when you pay attention to those preventative and small things. So I'd love for you to each share kind of about your experience on that.
Yeah, so one of the things that we did sort of early on, and I think really at that point, kind of based on the leaders who came together 7-8 years ago, was, so I come from more of a traditional mental health background. I had colleagues who came from a more traditional intellectual and developmental disability background, but we had sort of enough understanding of the system at large to start to put pieces together to say, did you know that this piece will pay for that and that piece will pay for this, and to really start to try and braid things together and and that is really what allowed us in the beginning to essentially get enough margin to start to innovate, was to think about funding differently and to say, okay, we're going to focus on the person and they need all these things. And we chose to make our lives very hard and go get certified and accredited and licensed through the state through essentially every system. So Department of Education, Department of Mental Health, Department of Developmental Disabilities, Department of Health, Department of Voc Rehab, Opportunities for Ohioans with Disabilities. Essentially every department at the state cabinet level, we went and got certified with now Department of Aging. And we built all of them. It doesn't matter. When you walk through the door, we're focused on what do you need, and now we're going to weave all of these things together to try and specifically meet the person's needs. So that was very expensive, and that was really sort of specific. But that is really what allowed us to start to innovate and to sort of pull together the margins to do creative things and to do interesting things and invest in measurement and data and actually be able to buy an analytics system and pay consultants who are much smarter than us to build dashboards and drive measurement-based care and all of those things, which then put us in a position to be able to almost stumble on in some ways. It was actually a transition-aged youth program that was a SAMHSA grant that we accidentally realized it was not one of the measurements of the grant. It was reducing hospitalizations for the youth who enrolled in the program. And not only was it reducing the number of hospitalizations, but it was significantly reducing number of days in the hospital if they went in the hospital by being part of this transition-aged youth program. Without first the money that came from weaving together all the systems and the investment in the data systems, and sort of like all of those things had to fall into place. And one of the things, and I think this is kind of the point, is that as a system, the people that we serve and the states, the communities, should not have to rely on a sort of weird array of events or all of the stars aligning in their state for one particular provider to actually get innovative care and to get care that is going to help move those families, those children, those communities forward. And so it's how do we take sort of how those stars aligned in our situation and actually make that what always happens.
Yeah, serendipitous isn't something that's scalable.
Serendipitous
right?
is not a business
Right,
model.
Right. Becky, how about you? I mean, America had some probably ability, I would imagine, to finance some of this on its own. How did you walk through that?
Sure. So I think you made a reference about turning the Titanic, which can be very difficult. But I will also say that when you get to sit down with payers or different state entities, being the Titanic, you're kind of large and in the room. So we have a couple different things. So in children's services, I'm fortunate enough that I get to blend the Department of Education dollars along with the Department of Human Services dollars, and then with the children and youth dollars, because we service a variety of payers for different needs. So that's helpful because we can sometimes get the education system to actually talk to the human service providers and or legal entities to provide services in schools. I think the other thing that's been interesting is we've been able to sit down with payers and states and look at evidence-based models along with case rates and then expense-based programming. Because we also find that the old fee-for-service model of reimbursement is very difficult to show your measurement base because you can't spend as much time with the family, and if the child's sick, then the clinician, and then they get into the whole workforce that we see. So it's been really important to look at how can we find data, find outcomes, and then pull together different funding or value-based measures or payments to then fund some of that to move forward. So we are very fortunate that we have a foundation and some grants that help us, but then also being in multiple states, we've been able to bring our success in one state to another state, and then partnerships with some vendors that are here we use as well to help collect our data and analyze it, and then make sure very large and big on outcomes.
See a theme here, outcomes and data. Yeah.
Data,
Yeah,
numbers.
yeah. Jay, you want to add into that?
Yeah, well, I'm fully on board with the importance of data. And so I think one thing I did not realize till I was at the state was how much of the data collection issues are like purely just mechanical issues, right? Like about pipes, right? There's this graph that we used to show that showed that we had like 14 different data systems that all led to nowhere. Like it was like 14 different bridges to nowhere. And part of what we were doing in CCBHC has allowed us, I keep saying us, has allowed Indiana to do is start to streamline that, because in order to do CCBHC right, you have to be able to report on really consistently and on a regular cadence and precisely on like 21 different data measures. So it sort of forced us to get everything correct. In general, kind of zooming out a little bit, I would say, in this space, I think there's generally two different buckets of problems, right? There are what I call scarcity problems, right? Where there's just way more demand than supply. And then there is what I call engineering problems, right? I call them that because they involve the flow of people, money, or information, through systems, and there's these bottlenecks. One of the things I'm looking at now is and where they kind of dovetail is that, scarcity problems generally require like additional policy or fiscal levers, right? You have to convince the legislature or convince, some payer to pay more in order to increase the supply in order to solve the scarcity issue. But when you go to the legislature and to make that case, you better have all of your engineering problems figured out, because they're going to say, why aren't you doing more with less right now? And if they can look at, there's this much waste or this much inefficiency within your system, it makes it really, really hard to convince them to help you fix the scarcity problem. So I think when we look at reimagining, right, to use a word that's really popular here, I've noticed, reimagining, these systems, we have to attack both the engineering side of it, which is all the things we're talking about in tech, and the scarcity side of it, which requires policy together instead of separately.
Yeah, that's great. We have a couple of questions, and I want to make sure I get to them, so I'll weave them in now. For Chris, did Shimmer look at intersectionality examples, LGBTQ initially as well? How did it change into focusing on ADHD, and how does that cater for further intersectionality?
Yeah, it might be a little bit of a product of the fact that I'm a lot of different underrepresented communities. So I'm very passionate about this. ADHD and neurodivergences look very different depending on what culture you are, where you grew up, what your background is, how your thought process is run, and not just in terms of what symptoms and how the symptoms show, but the expectations that the world has on you. So for example, being a woman with ADHD, the world expects me to be neat and organized and to do certain things in my household. And if you're a parent, if you're a mom, there's even more expectations put on you. So it's not just the symptoms look different, but also what society expects and therefore you expect out of yourself. So intersectionality is super important for us. It's always been in terms of what we do. And so, for example, if you are potentially an Asian person, like me, Asian queer person with ADHD, and me talking to someone, a coach who is also queer, who is also Asian, there's a level of understanding that I can be able to get that I can never be able to get if that's important to me. And different people, some things are visible intersectionalities and some things are invisible intersectionalities. And those things are really important to get right when we think about not just neurodivergences, but just mental health care at large.
And isn't that the beauty of technology, is that now you can find that and match that and deliver that, and it doesn't have to be based on a zip code.
Yes.
So
Yeah,
think that's
exactly.
terrific.
With coaching too, because it's not state bound,
Yeah.
we're able to find you that perfect coach. With some people, people are interested in all the different things. Some people say, oh, I have ADHD, but I also want someone who is into intuitive eating. And you can also find that. The match can get so specific when you actually get the right supply and demand actually matched up with the right algorithms.
I love that. Good for you. We have another question for others on the panel. What do you see as the role of self-directed budgets provided to family caregivers, especially with a limitation in home health workers? Yeah.
So one of the things that I actually talk about a lot is the sort of cliff that is in front of sort of this field, the neurodiversity system specifically, but also healthcare at large and behavioral healthcare at large, which has to do with the rise in these diagnoses that is happening alongside the aging of the population and people leaving the workforce in a larger number than has happened before. And so when you start to look at the math, and you realize with diagnosis of autism, now whether that's actual incidence or just better detection and diagnosis, but then you also look at the youth mental health crises and SUD and all of these things, you realize that there is a real math problem of there simply will not be enough people to serve all of the people who need care if we insist on serving them the way we always have, or if we insist on serving them the way we do today. And so I bring that up to say, I believe that it is a combination of leaning back into, so if we go back, and this is going to sound really weird, but if we look back 50 years, if we look back 60 years, the natural family systems, and whether that's chosen family or biological family, but the natural family systems and the community really were a big piece of how people were supported. And lots of great things happened, deinstitutionalization, we've made huge progress and great gains, but I do think that we lost something when we said to the families, thank you, mom and dad, thank you, family, thank you, church, thank you, local community, the professionals have got it and there isn't really a role for you anymore. And when we look at the math, we are going to need them. So we're going to need the natural family systems, we're going to need technology, and we're going to need the professional and paid caregiver workforce, that it's going to have to be a braiding of all three. And so when you think about things like self-directed budgets and having family members be much more involved, I actually think that's part of the sort of three-pronged braid that is going to happen if we're going to even come close to meeting the scarcity need.
Oh, just ditto to everything. That was brilliant. Thank you. That was really well said.
Well said.
You should join a think tank.
Life
I
goals.
can just interview her and like say, and then pass it off as my own article or something. So that's probably happening, just so you know.
Yeah. Anything to add on that, Becky? I know. Yeah.
No, I'd say well said as well. Like, I think.
Yeah. I think another theme in the questions is really around just kind of pivoting back to that onus of responsibility always on the provider, right? And so is there something we can do, and maybe that's where the lawyer turned DHS turned think tank can come in. Like, what do we do so this isn't always our problem to solve as community providers, right? I mean, you look around and you walk the halls of BHT. First of all, I want to just acknowledge that just having this panel at a conference of this size of national scale about technology and IDD is unheard of. Like, so kudos to Salome and team for this, right? Because if you would have told me 5 years ago that we could get a panel where there's 2 nonprofits on it to talk about behavioral health tech at a national conference, it would never happen. And so that in of itself is progress. But what else do we need?
Yeah, and there's something to go with this, but I think one of the issues that we have is we try to turn behavioral health care into like making widgets, right? Like A plus B equals C, and then you try to like rinse and repeat, and then you realize that people are a lot messier, right, than making widgets. And where that comes in, I think, is sort of what is our goal here, right? Our goal at the state is actually not to increase the amount of services provided. Our goal is thriving communities, and there's like a big difference between those two end goals. And I look at like economic development, for example, we pour tens of millions and billions of dollars into state-directed incentives to companies to basically do what's already in their best interest, right? That's essentially what state economic development strategy is. And I look at, could you use that same approach to focus on conditions of thriving, right? Not handouts to providers, but like, how can we, create the conditions where the natural family unit or, churches and other folks can step in that void. And so I think from my perspective, I'd love to orient the conversation away from like services or outcomes even to sort of more overall thriving. I know it's easier said than done, but that's my answer.
Stacey, if I could. So I think it's going to be really important. It's not a provider responsibility to solve the crisis that we have going on. It's going to take a lot of collaboration. It's going to take states and payers and providers coming together. I think what happens too often, though, is, no offense, the state. That's not you anymore, right?
Yeah, it's not me. I can say whatever I want.
He's not we or us anymore. Is really that widget making that you're talking about. Here's a fee-for-service model. Here's money. Go do this. Get that. And it's going to take some of the braiding that Jen was talking about, along with sitting down and saying, how do we move our community to a healthier, more thriving way? But I think the other thing is, as far as innovation, is really looking at how are we doing things differently. I know my home state of Pennsylvania, we have some very antiquated services. We still follow some of the same things we followed 25 years ago in the same way and everything. And I think that you made some really good points, Jen, and it's really going to take this collaboration as we pull together with both the payers, the states, and the providers. But I think it's mostly falls on the providers, though, because at the end of the day, we're trying to essentially keep our doors open to provide the service, and everyone wants to talk about the dollars and the cents, and I think it's really more about the outcomes and the quality of the community. And I don't necessarily mean the outcome of treatment of progress towards goals, but the how are we leaving our impact on the communities that are around us.
I love that. That's a perfect closing statement, Becky. I appreciate that. I encourage everyone to connect with us on LinkedIn, certainly to foster the growth of Shimmer. We want that, right? To do that, so use the screen, connect with folks on LinkedIn. Please join me in thanking this panel for a wonderful, wonderful pre-lunch conversation.